Bismillahirrahmanirrahim. I have the pleasure to present Dr. Sadam Hassan. He will present the title of DKD, the current paradigm. Father Dr. Sadam.
It's my pleasure to be distinguished from this and to have a rapid overview over the current paradigm of our current understanding of the DKD spectrum. I will not be spending very much time on the treating epidemiology and treating adverse events that happen with diabetes. Very well documented observation studies and that diabetic neuropathy, diabetes per se, is the leading cause of stage renal disease in countries in the world. Diabetes is the leading cause of non-traumatic blindness. Diabetes is the leading cause of non-traumatic amputation. But when it comes to diabetic nephropathy, the paradigm of diabetic kidney disease, this report was published by the Walter Creed, American scientists, who have found that the traces of metformin have reached to around 3.2 kilograms of the south coast of Michigan lakes, and this can give you the amount of metformin that has passed from the urine of patients in the US, and can tell you also the increasing amount of the metformin used for treatment of diabetes as the first option. But interestingly, this increased amount was found to affect the endocrinal system of the fish that will keep on kilograms per mentioning. So that's when it comes to the current paradigm, the topics I'll be addressing today is that we have been always focusing on the albuminuria issue, centering the glomerulus and the core essence of diabetic nephropathy, and oftentimes neglecting the doppler changes that happen in diabetic kidney disease. And the second issue is the conventional paradigms that have been always suggested for the intensive glycemic control, intensive blood pressure control, lipid management, salt restriction. We will challenge these paradigms and see what happened. And what happened over the last 2 decades when we used them. And then, quickly, in 1 or 2 slides, I'll try to show you some of the recent advances of the management of diabetic kidney disease. So, to start with, for years and years, diabetic kidney disease has been known as the 5-stage model that starts in patients with type 1 diabetes. This model was developed in patients mainly with type 1 diabetes, with normal serum creatinine, stage 1, then a stage of hyperfiltration with increased GFR, and then a stage of pseudo normalization where serum creatinine drops back to normal again, and then the stage of a progressive decline of glomerular filtration rate ending into end-stage renal disease. And it was suggested that this is always coupled with an increased and progressive urinary album secretion rates that starts from A1 according to the CQD guidelines 2012 to A2 to A3. And it was always cited that persistent albuminuria is the hallmark of diabetic nephropathy. You cannot speak of diabetic kidney disease unless you have increased urine album excretion rate and the range of A2. Otherwise, consider other disease, consider biopsy. However, when you take a closer look to what happens with microalbuminuria, albuminuria, macroalbuminuria, or A1, A2, A3, recent data suggests that at the high range, if you classify patients with A1, with normal albuminuria, at the old paradigm, it was found that in the high range of A1, patients experience more adverse cardiovascular events and progress more to chronic kidney disease. And if you look at the paradigm of albuminuria A2, it's a very highly variable measurement so that the term is to have persistent albuminuria. And we have seen from the on-target study that 30% of patients may even have spontaneous regression of albuminuria without any treatment. And then we have now the growing paradigm of the non-proteinuric phenotype that progresses to end-stage renal disease without experiencing the increased albuminuria. And this has differed according to the report study from 30% to 55%. And it was found in this Italian study that it was female sex and cardiovascular disease that predicted more patients to have non-proteinuric phenotype, but still an observational trend. And another important point is a huge debate in the nephrology society and research production. Could we stand and take albuminuria into as a renal endpoint? FDA has reviewed this issue. And now there is an increasing interest to have patient-centered outcomes. But also, it should be noted that albuminuria is a non-specific marker of endothelial dysfunction. So it may reflect also the increased risk of advancing cardiovascular disease. So it predicts both major adverse cardiovascular events and major adverse kidney events. And when we have the look at the decrease in the GFR paradigm, the recent Kadibu mini review issue that was published in Kidney International last year have admitted that cystatin-based estimated GFR is a better predictor of progression to death or end-stage renal disease, even more than creatinine. But they have also endorsed creatinine as the method of measuring estimated GFR, citing that the marginal improvement is very narrow to have this increased cost. But still, it's not the gold standard and the usually used paradigm is the serum creatinine. And when it comes to serum creatinine, it was also that there is a U-shaped mortality curve. At low estimated GFR, of course, it makes sense that there is an increased cardiovascular and progression to chronic kidney in the stage renal disease. But remarkably and interestingly, it was found that patients with the high estimated GFR, higher than normal, have also an increased risk of adverse cardiovascular events. Many analysts have tried to explain for this phenomenon, but it is still not clear why this happens. And when you look at the dissociation between the albumin secretion and decline of GFR, and try to compare them to what happens with pathology, and with this slide, there is the 4 stages of progression of diabetic kidney disease as proposed by the Renal Pathology Society, where patients progress from increased basement membrane thickening to essential expansion to nodular sclerosis to liver sclerosis. It was found that the changes that happen in the diabetic kidney disease precede what happens as the functional biomarkers. So there is complete association between structural injury and the functional paradigms we are using nowadays. There is an increased interest in the work of finding a suitable biomarker, but it's very non-zero. The performance is very bad until now, generally speaking. And there is an increased interest also to understand on pathophysiological basis what happens in diabetic kidney disease. And here comes the role of micro-small RNA, which can predict the metabolic abnormalities that happen in patients with diabetic kidney disease, and through citing any of those micro-small RNA, you can diagnose disease, you can predict the progression of the pathological process, and there is even interest to use them as therapeutic target. This will be a growing area of research for the next years. But let's see why we don't have the exact model to explain what happens in diabetic kidney disease. First of all animal models are completely unfaithful to what happens in humans. We couldn't develop a remarkable animal model to study what happens in diabetic kidney disease. And when you look at the old and current paradigm, you'll find that patients showing hyperglycemia, and should be noted that hyperglycemia is only the phenotype of many diseases, like insulin resistance, beta cell dysfunction, metabolic syndrome, or diabetes, or obesity. And this hyperglycemia drives the alteration on the afferent and efferent arteriolar vasomotor regulation, ending in dilation of the afferent arteriole, vasoconstriction of the efferent arteriole, and increasing the glomerular capillary pressure, which then spills over to the whole circulation, causing systemic hypertension, but at the same time causing glomerular hyperfiltration. But we often neglect that there is a glomerular feedback that senses the delivered sodium and chloride at the proximal and distal tubules just to regulate this vascular tool once more. And to see what happens. Albuminuria was found to be not only a marker of glomerular injury, it's now increasingly cited as a marker of tubular injury. And what happens is that we have discovered the transporters present in the proximal convoluted tubules of albumin. What happens is when albumin is filtered from the glomerulus, reaches the proximal convoluted tubule, and when we have an identification of the proximal convoluted tubule, we find that cotinine transports albumin from the normal tubule to the tubules once again, inciting very intense inflammatory vascular and fibrotic actions. So that tubules also are included in the process of albuminuria. What happens? And when you have a closer look at the proximal convoluted tubule and divide them into S1, S2, S3, you will find that there is an increased recognition of the family of sodium glucose transporter 1. And just to give you the importance of those transporters, the sodium glucose 1 that is present in the proximal convoluted tubule in S2 and S3 segment is also present in the GIT. It's the carrier used in the oral dehydration solution. And it was cited that the most great treatment discovered in the 20th century was oral dehydration therapy, because it saved the lives of millions of children who are dying from dehydration. And now there is an increased interest of the action of the sodium glucose transporters 2, which are present in the first segment of the proximal convoluted tubules, and they are responsible for absorption of more than 90% of the filtered glucose that reaches. And what happens is that when they have the increased the absorption of glucose, they couple that with sodium absorption, ending in the delivery of extensive amounts of glucose and salt to the distal tubule. But in diabetic patient, the total glomerular feedback that should sense this and tell the afferent arteriole constrict is not present anymore. And so that what happens here is that you have an increased absorption of sodium glucose reaching from the proximal convoluted tubule to the distal tubule, where it should be sensed here at the macula densa just to decrease the absorption, but this doesn't happen in diabetic patients, ending in the increase of the single glomerular filtration rate. So that you can now feel that glomerular hyperfiltration may be a tubular derived process. And this is very interesting. Because simply, if you can block this signal, if you can restore this status and decrease the sodium and glucose reabsorption, then the amount of sodium and chloride reabsorbed can be again filled by the macula densa present in the proximal convoluted tubule, and then you can decrease the glomerular hyperfiltration, so that you can treat glomerular hyperfiltration from a tubular method. And these are very exciting. So that if we look at the new paradigm now suggested for diabetic kidney disease, it could be some event driven by a tubular event that happens with increased salt intake, increased hyperglycemia, both ending in the increased absorption of sodium and glucose, ending in glomerular hyperfiltration, albuminuria, and then repeat episodes of acute kidney injury. And this is a very important issue, because many of the patients we have found to have end-stage renal disease due to diabetic kidney disease do not have the paradigm of proteinuria. So most probably, it's expected that they experience repeated episodes of acute kidney injury, ending in non-proteinuria end-stage renal disease. To be fair, we should balance what happens in the glomeruli with what happens to you, and be aware when we are treating our patients of both processes together. We cannot stress treatment, glomerular aspects, and neglect what happens in tubules. And let's see the current paradigm of treatment. This is from the last review from KD guidelines. They suggested the usual dogma, control, intensive glycemic control, intensive blood pressure control, RAS inhibition, lipid management, to improve the outcomes of cardiovascular and stage renal. And I will start by RAS inhibition and blood pressure control, because RAS inhibitors are always indicated as the best treatment for diabetic kidney disease, for hypertension. There is now an expanded universe of the receptors of the RAS system, which starts from the renin, prorenin, to renin, and then transforms from ACE1 towards on a various family of receptors. And it was found that blocking some of those receptors could actually be harming the tubules and the glomeruli, because they are not all fibrotic. They are not all vasoconstricted. They are not all growth factors. And there is increased interest in this family and in more experimental trials trying to find agonists instead of antagonists for this family from angiotensin 1 to 7. And let's see what happened in diabetic nephropathy. ACE and ARBs were tried in every step of diabetic nephropathy. It was tried in pre-diabetic patients in the DKD trial, in the diabetic patients with microalbuminuria, the roadmap and Benedict trial in that trial. By the way, roadmap ended in decreasing albuminuria, but enhancing cardiovascular risk. So that was prematurely stopped. And then the trial of stopping the progression from microalbuminuria to macroalbuminuria, and the EMA2 trial, one of the successful trials, and then the advanced trial that was 2x2 bacterial design for blood pressure and glycemic control in 2 arms. And there was increased cardiovascular adverse events when you try to block for proteinuria, and also increased episodes of acute kidney injury and hyperkalemia in this trial. And so was what happened in the IEMT trial. So that you can give an agent that blocks what happens in glomeruli, you can stop proteinuria, but you will not stop the progression of diabetic kidney disease. Simply because you have transferred the load to the tubules, which suffer in the absence of this angiotensin 2, leading to repeated episodes of AKI, and then the same result happening. You have an end-stage renal disease patient, but without proteinuria. What the deal? So that there was many trials to enhance the performance of RAS inhibitors. Many trials have concluded that the doses needed to completely abolish proteinuria are huge and are above that doses needed for blood pressure control. And the more doses they increase, the more acute kidney injury patient has. It was supposed that salt restriction can enhance the action of ACE and ARBs, and this is a special issue that Sir mentioned, I'm sure, again. And then double blockade through sequential blockade, and with ACE and ARBs, with renin, direct inhibitors, ACE and ARBs, and so on. And then was the addition of the vitamin D receptor analogs to the ACE or ARBs, as what was happening in the Bible. So let's see what happens on target. The addition of ACE to ARBs, less proteinuria, increased acute kidney injury, more hyperkalemia. The altitude drug. Hey, addition of direct allosterine inhibitor to ACE completely. The Vanetron trial, the last reported trial, with losartan was added to this control. Less proteinuria, more acute kidney injury, more hyperkalemia. Interestingly, if you are not prohibiting your patient from excessive salt consumption, when you are putting him on ACE inhibitors or ARBs, in diabetic patients, happens what's called the salt paradox. Simply, when you are giving him ACE or ARBs blocking this axis, the salt loading that the patient is taking from diet can bypass all of those pathways and directly stimulate mineralic corticoid receptors, ending on excessive vasoconstriction, excessive fibrosis, excessive growth, and all the side effects that you will try. So that if you are prescribing ACE or ARBs, make sure that your patient is well salt control. It's very important. Interestingly, too, In the trials of double blockade, we have confirmed that the low salt intake ended in more and higher acute kidney injuries and higher serum potassium, even when patients were matched for the double blockade. Meaning that if you have extreme salt inhibition, fortunately this doesn't happen in Egypt, but there is an increased risk of acute kidney injury with plasma. And if you don't give the patient the right paradigm for salt control, you will not have the benefit from the ASO. So that this was the opposite view of the current paradigm now, and this man, together with the Nahas, are very, very against the excessive use of brass blockers. And I will show you what he says. He said that it's a perfect plan because there is multiple breakthrough and escape phenomena that happen at the posterior and and we have an increasing paradigm of non-proteinuric progressors so that we do not need it that much. And we should and must know that up to 30% of patients diagnosed as diabetic kidney disease have underlying ischemic nephropathy, and they may have excessive harm from the excessive use of brass. But also, trials have shown that it can be sometimes deleterious when used early in the acute diabetic kidney disease and even late. And it has a trial. He has patients at stage 4 and 3, and he stopped the ACE with able, and then a patient improved and when in conservative management for a while. So that the full message here is that use ACE and ARBs, okay, with salt control for the appropriate patient. You stop them if the patient has any evidence that can predispose him to acute kidney injury like systemic illness, fever, dehydration, or whatever. And moderate your use. Do not target just the proteinuria, okay, and forget the blood pressure. This is the first paradigm. When it comes to the second paradigm, the glycemic control, I don't be taken very much. This glycemia was tried to be controlled both in acute kidney and chronic kidney disease. And of course, the monitoring of glycemic control in diabetic patients is problematic. It's really problematic. Glycated hemoglobin is very variable according to the level of anemia, the AC administration, the iron administration, vitamin C, vitamin E, the change in patient hemoglobin. So that's not that accurate. However, it's the only outcome surrogate that has been tested in trial. Any trial in diabetic nephropathy will be citing the outcomes like glycated hemoglobin. Glycated albumin was found in many studies to be more sensitive and more predictive of cardiovascular events, especially the ischemia-induced albumin cure, and also the progression to end-stage renal disease. However, it's not validated by the trials. Fractosamine is having more and more lab. Of course, the gold standard remains the continuous glucose monitoring, which is not feasible for the time. That's why both Kadibu and European renal test tracks endorse glycated hemoglobin as the best surrogate right now to be used in the glycemic control, but also citing the drawbacks and shortcomings. The increased reports of sugar substitutes, and it supposed that the increased substitutes and then increase of uric acid, triglycerides, and then leading to more hyperuricemia, more cardiovascular disease, and more episodes of acute kidney injury. And this has been also illustrated in the Afro-American and the Mesoamerican nephropathy, where patients working in canned sugar were exposed to acute kidney injury. This is a matter of...
Would you mind time, please? Mind time.
So that's what happens. When you have intensive glycemic control in the acute setting, there was increased mortality. So that the recommended now is between 140 to 180. And in the glycemic control, when you have early glycemic control, you will have the benefit. This was proved from the type 1 diabetes control complication trial and type 2. And it was found that even if you lose the control after an initial period of tight control, the patient continues to have the benefit whatsoever the legacy effect or the metabolic effect, and there is a growing interest of what happens to make some patients not prone to long-term adverse effects after initial control. trials that have tried glycemic control late, first of all, most of them didn't report unless on soft forms, microalbuminuria or microalbuminuria. Only the advanced trial reported on WBCR creatinine. And what was found is that by post-hoc group analysis with the decrease of glycated hemoglobin, there was a decrease in the progression of chronic kidney disease, but at the expense of increased cardiovascular mortality, maybe due to hypoglycemia, recurrent or whatever happened. So that you would not accept that trade. So that when you use high glycemic control early, as what happened in type 1 and type 2 diabetic patients, you have the metabolic effect or legacy effect or whatever happened, it's supposed to be an epigenetic change. But if you try with a versatile diabetic patient, try to have sure that they have enhanced cardiovascular mortality. You are treating their kidney, but killing cardiovascular. And then we come to the last point, which is lipid management. Lipid management is one key level in CKD non-diabetes patients and transplant patients. And this is mainly for the improvement of cardiovascular outcomes, and most of those data have come from post-hoc subgroup analysis. And in diabetes patients, negative outcomes have been reported in the 4D Aurora and Sharp study, so that a policy now is not to issue, but also not to stop, so that it's not to stop and not to issue. The coming opportunities come with trials trying to address further aspects and signals along the way of diabetic nephropathy. This one is acting on antioxidants, albuminol and NSL sustained naked. Another one acting on acetylcysteine. This one will make it excessive heart failure. Still, blood is in the plan. And creatine, of course, is added to other factors, including blood sugar. And when you go down the pathway, some of them have been reported with negative outcomes. And the problem is that when you just target one signal, those signals are very pleiotropic and maybe context-specific. Maybe some signals are very active but alien in diabetic disease, and when you try to control them, they are already cut. And also, there may be off-target adverse events that happen, and this what will be next research to us. So that in summary, care for the universe, but on. Thank you.
Thank you so much for this very kind. It's a very good presentation, actually. Good language, good slides. And I wish this will come at the end of the meeting, because it summarizes all what has been happening the last few days, actually, at the meeting. So it comes with a very nice summary. But first of all, can I just ask you to just highlight the linguistic meaning of the word paradigm?
Yes, the paradigm is like a conceptual model. So that when you adopt some dogma or some track or some...
Right. Is there an Arabic word?
paradigm al-mathal or namudak.
Right.
The current paradigm stands for the what we understand.
We can accept one or two questions from the floor if anyone. Any comment from the panelists? Right, if so we have to move.